I'm so far behind. One of the reasons I haven't done very much braiding lately is because, well, first of all, they threw me behind by turning everything off and not turning everything back on. That was funny. And the other thing that happened, or that the other thing that's going on right now, is that it's cherry harvest season, and we've got a cherry bush that we've already picked over eight gallons from. 8 gallons of cherries. That's a lot. Everything became ripe at the same time. It's funny, or not so funny. Anyway, that's the only excuse I'm gonna make. I'll catch up. Okay, so let's go ahead and get started. This week we're talking about anxiety and phobias and obsessive compulsive disorders. There you go, a tarantula, just what everybody needs to see this early in the morning. Actually, it's 4:30 in the afternoon where I am. Anyway, there we go. Okay, anxiety and obsessive compulsive disorders. This is chapter 6. This is something I've never suffered from, PTSD, but nothing else, nothing more severe than that. Anxiety symptoms occur quite frequently in the United States. The category of anxiety and obsessive compulsive related disorders comprises the most common of the DSM-5 diagnoses, with lifetime prevalence rates of over 28% of the population, and that's almost a third, so that's pretty good. That's a lot. And the DSM-4, obsessive compulsive disorder, was included in the anxiety disorders classification. However, in the DSM-5, anxiety disorders and obsessive compulsive and related disorders are now two separate classifications. And this is one of the things that they do when they decide how to put the DSM together. DSM-5 anxiety disorders include panic disorder, agoraphobia, which is fear of the marketplace, or individuals that are afraid to go out of their house. Specific phobias like arachnophobia that we just saw, social anxiety phobia, fear of making a speech or being caught in public. Generalized anxiety disorder, which is just all of a sudden anxiety just kind of hits you. Separation anxiety disorder, where you're afraid to be away from. It's usually your mother. This is usually a childhood thing. Selective mutism. If you ever saw Big Bang Theory, at the beginning, Raj couldn't speak to women. That was selective mutism. And other anxiety disorders. That's in DSM-5. The DSM-5 classifies I'd show you a picture, but well, what does it look like when you're having anxiety attacks? The DSM-5 classifies the different anxiety disorders in part based on the occurrence of certain components of the anxiety symptom complex. Two such components are panic attacks and agoraphobia. Many of the anxiety disorders in the DSM-5 involve one or both of these components, but all involve intense uncomfortable fear or anxiety as the main presenting symptom. So usually what happens with any of the anxiety disorders, it starts out with a panic attack, and then they're afraid. They become paranoid. They're afraid to go out of their house. They're afraid to move. Afraid to, be someplace. So both of these are components of most anxiety disorders. Bob is a 22-year-old carpenter. He has been referred to a psychiatric outpatient unit. During the initial interview, Bob is visibly distressed. He appears tense, worried, and frightened. He sits on the edge of his chair, tapping his foot and fidgeting with a pencil. It has been an awful month. I can't seem to do anything. I don't know if I am coming or going. I'm afraid I'm going crazy or something. And this is Dr. Benson. She says, "What makes you think that, Bob? I can't concentrate. I start to do something and then forget what I'm doing. My heart races. I get dizzy. What are you thinking when you feel like this? I think my heart is going to explode. My head is swimming. My ears are ringing. I must be dying. What happens then? The intense feeling goes away, but leaves me drained. The sweating and racing heart. Ugh. Bob is suffering from generalized anxiety disorder. Anxiety is another word for vague sense of being in danger. Anxiety's features are much like Bob's symptoms: increase in breathing, muscular tension, perspiration, and feeling of fear. Anxiety is actually crucial in the survival of humankind. When confronted with a danger, anxiety prepares the individual to fight or flee. The anthropologic man who did not have a proper level of anxiety ended up as some lion's lunch and therefore dropped out of the gene pool. On the other hand, the man who would flee at any confrontation probably wasn't very popular with the ladies, and he was scared out of the gene pool. Like Goldilocks, our level of anxiety is just right. But sometimes it tips one way or it tips the other way. Anxiety disorders are the most common mental disorders in the United States. In any given year, 19% of the adult population suffers from one of the 6 categories of anxiety disorders. The disorder costs the country in the neighborhood of $42 billion in lost productivity, lost wages, and increased healthcare costs. Anxiety disorders are often paired with other disorders, or comorbidity is about 81%. So you normally tend to not have just an anxiety disorder, but it's an anxiety disorder with depression, anxiety disorder with paranoia. You can, they're ADHD. I mean, they're just anything you can pair it with. Stress is a feeling of threat, and we talked about stress last week. Stress is a feeling of threat that causes the body to change. Stress has 2 components: the stressor, that which creates the stress response, the person's reaction to the demand. Anything can be classified as a stressor, from trying to be happy to military combat. People who feel that they can handle stressors will cope in any situation. Other people may buckle under any degree of stress, and we noticed. I saw this in the emergency room. Some people can handle the emergency room, other people can't. I mean, it's really cool when you get a bunch of nurses and doctors that are working in the emergency room, and every time something comes in, they just handle it. That's really good. I was in charge of a specimen collection at a major trauma hospital in Omaha. And I can tell you there were some people that we could send to the emergency room for an emergency, and there were other people that you couldn't, because they couldn't, even if you sent them down there, they're all spooked out, and when they tried to draw blood, they couldn't get their blood. It was just bizarre. And there are other individuals that handled it really well. So you had to be selective as to who you sent to the emergency room. Fear can be a good thing. It is fear that tells us to run from the lion. The fear prepares our body for optimum performance and thus optimizes our possibility of surviving. We perspire, our breathing quickens, our muscles tense, our heart beats faster, we turn pale, we develop goosebumps, we feel nauseated. Emotionally, fear may make us feel horror, dread, or panic as long as it gets our feet moving. Cognitively, our rational thought and concentration will be disrupted. We may remember the incident incorrectly because our brain was dealing with worst-case scenarios. Recollection will probably deal more with probable than real. Our fear response occurs automatically. In fact, it is controlled by the autonomic nervous system, which controls involuntary activities. Hence, we didn't have to consciously increase our breathing. When our brain interprets a situation as dangerous, the autonomic nervous system kicks in turn activates the sympathetic nervous system, causing us to be prepared to fight or flee. One of the glandular areas activated is the top of the adrenal glands, or the cortex. This area will produce corticosteroids, a substance that acts as a short-term infection blocker in case that lion makes a hole in our protective covering. It is corticosteroids that makes the person feel anxiety. Jill had gone downtown shopping just like any Saturday when it hit her. Everything went black, sweat poured from her. In seconds, her clothes and hair were soaked as if in a rainstorm. All the blood drained from her face, and she was as white as a ghost. Her knees buckled, and she couldn't move to sit down. People looking at her lost their bodies and merged into one huge face. Her heart started pounding so loudly that her ears hurt from the noise. She knew that she had to get away or die. Only fresh air would save her. Jill is suffering from a panic attack. Panic attacks are periodic, short bouts of panic that occur suddenly and reach a peak within 10 minutes and then gradually pass. Panic attacks have any four of the following symptoms: palpitations of the heart, tingling in the hands and feet, shortness of breath, sweating, hot and cold flashes, trembling, chest pains, choking sensations, faintness, dizziness, feeling of unreality. Anyone can suffer from a panic attack when they are faced with something they dread, but someone who suffers from panic disorder will have repeated panic attacks unexpectedly without apparent reason. Sometimes, when individuals have had repeated attacks, they begin fearing more attacks. Often, recurrent panic attacks will lead to a fear of going out, which eventually becomes agoraphobia. Fear of leaving one's house or being in public places where there is limited avenues for escape. 4 weeks later, she had a similar attack. She had 4 more attacks in the next 7 weeks. She began thinking about the attacks so much she feared leaving her house, not wanting it to happen in a place where she couldn't get out. She no longer rides in cars or subways for fear of being trapped. Was that Anne? Oh, that was Jill. Not everyone develops agoraphobia from panic disorder, but many do. 2.3% of all people in the United States suffer from one or the other of these patterns in a given year. 3.5% develop one of the patterns at some time in their lives. Both disorders tend to develop in late adolescence or early adulthood. Women are 2.5 times more likely to develop it as a man. Onset is typically between adolescence and the mid-30s, and the course is highly variable. Although almost any pattern of attack is possible, the most common appears to be a chronic one of waxing and waning symptoms. Antidepressants act to restore the proper activity of norepinephrine in the locus ceruleus. This seems to control panic disorder. 80% of sufferers from panic disorder who take antidepressants show some improvement. 40 to 60% show marked or full improvement. This improvement can be maintained as long as the individuals take their antidepressants. Xanax has the same effect. The treatment also works on panic disorder with agoraphobia. Researchers have discovered that people who scored high on an anxiety sensitivity survey were 5 times more likely to develop panic disorder. Many of these people tend to overbreathe or hyperventilate in stressful situations. The breathing problems are just the beginning of a downward spiral of fear that may end up as feelings of insanity or a heart attack. People who are prone to panic often interpret bodily sensations in ways that are not at all common. Some people experience fairly severe anxiety despite the lack of stressors. This used to be known as free-floating anxiety, but is now called generalized anxiety disorder. The symptoms are excessive and continuing anxiety for at least 6 months, difficult controlling worry, restlessness, easy fatigue, irritability, muscle tension, sleep disturbance, significant distress or impairment. It isn't that they are looking for something to worry about. It is the fact that they see the world as hostile and worthy of worrying about. In any given year, 5% of the American population and 3% of Great Britain's population will suffer from this disorder. Worriers appear in childhood and adolescence. Women outnumber men 2 to 1 among the worriers. The more actual dangers that someone faces, the more likely they will develop generalized anxiety disorder. One of the most powerful forms of societal stress is poverty. The stress rate for people living in poverty is twice that of people living in more affluent circumstances. In any given year, 6% of African Americans suffer from the disorder compared to 3.5% among the white population. Existentialists feel that generalized anxiety disorder is caused by existential anxiety, fearing that there is a limit to one's existence. They can recover by taking more responsibility in their lives. Like all other problems, generalized anxiety disorder is caused by dysfunctional ways of thinking. To treat this problem takes facing one's own basic irrational fears, namely, need to be loved by everyone, things should always be the way the client wants them to be, dangerous or fearsome things should be focused on, one must be totally competent to be worthwhile. When any stressful event is interpreted through these irrational fears, they are extremely anxiety producing. There are two basic therapy techniques that are used to treat generalized anxiety disorder with cognitive therapy. Changing maladaptive assumptions, the therapists point out irrational assumptions, applying more appropriate assumptions, and then assigns homework or practice. Teaching clients to cope. Teaches clients to stop fearing irrational ideas by understanding that they have the ability to cope with any crisis. Biological theorists feel that generalized anxiety disorder is caused chiefly by biological factors. The most obvious cause is that it runs in families. Approximately 15% of the relatives of generalized anxiety disorder sufferers display it as well. This is higher than the 4% of the general population. Researchers discovered that gamma-aminobutyric acid, or GABA, blocks anxiety. When there is a decrease in GABA, the client tends to be anxious. The anxiolytic benzodiazepine, Xanax and Valium, replaces the GABA. The most successful treatment for the reduction of anxiety is treating the patient with anxiolytics, or anti-anxiety drugs. There are three categories that work. The oldest and largest are benzodiazepines. Xanax, Valium, Ativan, Klonopin, Librium, and Cirex. Two other drugs that work as anxiolytics are the azaspirones, Buspar, and the beta blockers, Inderal and Tenormin. The SSRIs Nardil and Parnate can be used. Non-pharmaceutical Nardil and Parnate, those are Nardil and Parnate. Oh, my mind. Okay. Probably not the best thing to take, Nardil and Parnate. Non-pharmaceutical treatments for anxiety includes relaxation training and biofeedback. Relaxation training teaches the generalized anxiety disorder client to practice relaxation techniques whenever anxiety appears. The improvement to the client tends to be modest. Biofeedback using a mechanical device informs the client when they are about to suffer from generalized anxiety disorder. When the biofeedback device is activated, it means that the client is about to have an anxiety attack. When this occurs, the client begins practicing relaxation therapy to keep the anxiety from occurring. The most frequently used mechanical device is the EMG or the electromyograph. The device measures muscular tension that is a precursor to anxiety. Phobias are an unreasonable fear of a particular object, activity, or situation. Wait a minute. Just a second. Nardil and Parnate. Nardil, antidepressant. Side effects. What am I thinking? Yeah, that's it. They're monoamine oxidase inhibitors. Okay. There's a problem with monoamine oxidase inhibitors. Nardil and parnate are monoamine oxidase inhibitors. There are a lot of dietary restrictions, and it can be very dangerous to take these. So, despite the fact that they say that you should or can take Nardil and parnate, not the best idea in the world. There you go. Anything else is better. Any other SSRI is better than Nardil and parnate. Probably not taking a pharmaceutical at all would be the best idea in the beginning. If it doesn't work, then you can go to Xanax. The benzodiazepines, they would probably go to selective serotonin reuptake inhibitors next. Um, Buspar is does it increase your serotonin? Beta blockers tend to be blood pressure medicine. And both of these are blood pressure medicines. Okay, so that's what the whole Nardil and parnate thing is, they're monoamine oxidase inhibitors. That's what I was thinking. While being afraid of something is very common, phobias differ in that they are more intense and persistent, and the desire to avoid the object or situation is greater. Phobias are so strong that they may interfere dramatically with an individual's personal, social, or occupational lives. 10 to 11% of adults will suffer a phobia in any given year, and 14% of adults will develop a phobia in their lifetime. Now, I have a brother that is afraid of snakes. I didn't know that. I didn't know that. He's my older brother. And of course, we've always competed against one another. And if I had known, it's a good thing I didn't know, because I probably would have tortured him. I'm not afraid of snakes. I'm not afraid of spiders. I'm not afraid of any. No, that's not true. I don't like rodents. But I would say I don't have a phobia against them. My cats catch them all the time. There are 3 categories of phobias. Specific phobias are intense fears of a specific object. Social phobias are fears of social performance or situations where embarrassment may occur. And agoraphobia is the fear of going into public places alone. Agoraphobia is almost always accompanied by panic attacks and are more likely to occur when the feared area has no obvious avenues of escape. 50% of women and 10% of men suffer from arachnophobia. They're afraid of spiders. My wife is afraid of tarantulas, and she's lived in that part of the world. The second most common phobia is social phobia. Okay, so he turned his back on the audience because he has social phobia. It's rude to laugh behind someone's back. Unless it happens to be a painfully shy comedian, then it's rude not to, as weird as that is. Third most common fear is the fear of flying, or aerophobia. The fourth most common fear is agoraphobia, or the fear of going out and not being able to escape in a crowd. The fifth most common phobia is claustrophobia, fear of tight spaces. Specific phobias are intense fears of select objects. Every year, 9% of people in the United States have symptoms of a specific phobia. The most common specific phobias is fear of snakes, or ophidiophobia, arachnophobia, fear of spiders, or acrophobia, fear of heights, paganophobia is fear of beards, and hematophobia is fear of blood. Claustrophobia, fear of tight spaces. Nyctophobia, fear of the dark. Necrophobia, fear of corpses. Demonophobia, fear of demons. Cynophobia is fear of dogs. Coprophobia is fear of feces, poop. Pyrophobia is fear of fire. Aerophobia is fear of flying. Spermophobia is fear of germs. Homophobia is fear of homosexuality. Hippophobia is fear of horses. Maisiophobia is fear of pregnancy. Sciophobia is fear of shadows. Hypnophobia is fear of sleep. Tachyphobia is fear of speed. Xenophobia is fear of strangers. Ergasiophobia is fear of surgery. Hodophobia is fear of travel. Hydrophobia is fear of water. Dermatophobia is fear of injury. And triskaidekaphobia is fear of the number 13. Anthrophobia is fear of human beings. Entomophobia is fear of insects. Mechanophobia is fear of machinery. Gamophobia is fear of marriage. Musophobia is fear of mice. Oculophobia, this is one I do have. Fear of crowds. I don't like to be around, don't like to be in that much of a press. Phonophobia is fear of noise or loud talking. Actually, I'll tell you, I'll talk about oculophobia in just a minute. Asphyxiophobia is fear of body odors. Osmophobia is fear of odors. Satanophobia is fear of Satan. Cypridiophobia is fear of sexual intercourse. Now I'll tell you about my oculophobia. I had oculophobia when, or I suffered a bout of oculophobia. We were in Amsterdam, and I can't swim. I can't swim. And we were with my kids, and we were walking down the canals, and the crowds kept pushing us toward the canal. And since I can't swim, I was afraid my kids would get knocked into the canal, and I wouldn't be able to save them. That's the aquaphobia that I suffer from. Anytime when my kids were young and we were in a crowd, I had the fear that I would lose them, that I'd lose hold of their hands and they would be pulled away from me somehow. That's the aquaphobia I have, but it's not real fear of crowds. I can be in a crowd now that my kids are in their 50s. I don't have to worry about it. I would be afraid of I was with my grandson, I guess, but he's pretty big now. He's almost as big as I am. 90% of people with specific phobias do not seek treatment. Specific phobias can develop at any time, but most animal phobias develop in childhood and continue to manifest themselves in adulthood. Phobias that begin in adulthood tend to be especially stubborn and tend to only improve with treatment. Social phobias are severe, persistent, and unreasonable fears of social or performance situations in which embarrassment may occur. They may be narrow, fear of talking or performing in public, eating in public, using a public bathroom, or riding in front of others. They may be more general, the fear of performing in a public forum. 8% of the population may have social phobias. 3 women have it for every 2 men. Social phobia. Behaviorists feel that phobias are cases of either classical conditioning or modeling. A child sees a snake, that's the conditioned stimulus. They see it slither mysteriously away, creating fear. That's the unconditioned stimulus. They develop fear, unconditioned response. The next time they see a snake, the conditioned stimulus becomes a conditioned response in the form of fear. When you see a snake and you see it slither away mysteriously, that scares you. Now it has become a conditioned response. If a stimulus is ever presented in conjunction with a fear response for something else, the individual may mistakenly equate the fear with the non-fear producing stimuli through stimulus generalization. The most common method of dealing with a phobia is through exposure treatments, exposing the client to the fear-inducing stimuli. There are 3 types of exposure techniques: desensitization, flooding, and modeling. Systematic desensitization is a technique developed by Joseph Volpe. The individual is given relaxation therapy, and then the fear-inducing stimuli is introduced incrementally. The client is asked to create a fear hierarchy, which by using the relaxation therapy is gradually introduced to the client from least fear to greatest fear until the client is comfortable with the formerly fear-inducing stimuli. And flooding the fear-inducing stimuli is presented en masse, like being thrown in the deep end of a pool and forced to swim. In modeling, the client observes other people handling or dealing with their fear object. Eventually, they too can handle the fear object since they have modeled so many other people handling it. Obsessions are persistent thoughts, ideas, impulses, or images that seem to invade a person's consciousness. Compulsions are repeated and rigid behaviors or mental acts that people feel they must perform in order to prevent or reduce anxiety. However, obsessive compulsive disorder is excessive and unreasonable obsessions causing great anxiety and compulsions to reduce or prevent the anxiety. Georgia can't go to sleep until she is sure everything is organized for the morning. She cleans all day to ensure herself that things will be perfect. Then she won't feel like things are getting out of control. Her children and husband walk around afraid to get anything dirty for fear of driving her into another frenzy of cleaning. Her obsession is that everything be perfect, and her compulsive behavior is her constant cleaning. As many as 2% of the people in the United States and Great Britain suffer from obsessive compulsive disorder in any given year. It is equally common in both men and women and begins in young adulthood. The problem may continue for years, but the symptoms tend to fluctuate from bad to worse. Many sufferers are depressed and many have eating disorders. Obsessions are thoughts that feel both intrusive and foreign to the people who experience them. Attempts to ignore or resist these thoughts may produce even more anxiety. People are usually quite aware that their thoughts are excessive and inappropriate. They may take the form of wishes, i.e., that one's spouse might die, impulses, repeated impulse to yell obscenities at work or church, images, fleeting visions of forbidden sexual scenes, ideas, notions that germs are lurking everywhere, doubts, concerns that one has made or will make a wrong decision. Harvey spent hours every night rehashing the day's events. He especially dealt with interactions with teachers and friends, endlessly making right in his mind any and all regrets. It was like replaying a videotape of each event over and over in his mind. He kept asking himself if he had acted properly and telling himself that he had done his best or had said the right thing every step of the way. When he did this during the day, he would be surprised how much time such things took. Compulsive behavior is technically under the voluntary control of the individual. However, the people who have compulsions don't feel that they have a choice as to whether to do them or not. These individuals recognize that their behavior is unreasonable, but they feel at the same time that if they do not perform their compulsions, something bad will happen. After they perform the compulsive act, they feel less anxious for a short time. Many people develop elaborate rituals that they must perform in order to feel comfortable. Compulsions can be grouped by type. Cleaning compulsions are probably the most common. These people feel they must clean continuously to get things to a level of cleanliness that will keep them safe. Checking compulsions are also common. These people must check door locks, gas taps, light fixtures a select number of times before they are sure it is properly disengaged and can't do them any harm. My first wife had a checking compulsion. Uh, and guess who had to do the checking? She'd send me back into the house to make sure the stove was turned off, to make sure the back door was locked, to make sure the television was off, to make sure she hadn't hit the stove and turned it on unbeknownst to her, to make sure that the gas was still on. Could I smell gas? And of course, every time I came we were leaving and I came out and I'd already checked everything, she'd say, "Did you check everything?" And I'd say yes. And she'd say, "I don't believe you. You need to go in and do it again." Uh, that was fun. Order and balance compulsions, where things must be arranged in a select fashion for someone to feel comfortable. It was worse than that. When we came home from someplace, I she wanted me to check for intruders, so I had to check under all the beds and then all the closets to make sure there wasn't anybody in the house. That was interesting. And of course, she claimed that I never did it, and that I needed to do it again. It was fun. I don't know that she has those same compulsions now. She was kind of young when I married her. She was only 18 when I married her. Order and balance compulsions, where things must be arranged in a select fashion for someone to feel comfortable. Touching, verbal, or counting compulsions, rituals of touching, talking to, or counting select items before the individual can feel comfortable with them. Nonek was a great football player, but sometimes missed the kickoff because he couldn't get his locker arranged right. He would spend hours after practice arranging his uniform for the next day. They finally had to hospitalize him when he missed a game, during which the trainer counted him rearranging his locker 365 times. The locker room crew had noticed missing jock straps, but after the hospitalization, they began finding them stuffed all over the locker room. Nonek just couldn't figure out how to fold them properly, so he had to hide them. Way to go, Nonek. Since we all have intrusive thoughts, but only some of us develop OCD, the characteristics of people who develop it include they tend to be more depressed than other people, they have high standards of conduct and morality, they believe that their thoughts are equivalent to actions, they believe that they can and should perfect control over their thoughts and behaviors. A discovery in medications has given researchers an insight into the cause of OCD. The discovery that treating the client with antidepressants increases the serotonin level has pointed the finger toward the regulation of that neurotransmitter as a cause of the problem. Two areas of the brain seem to be the location of obsessive thoughts: the caudate nuclei and the orbital frontal cortex. Together, these structures create a circuit that converts sensory information into thoughts and actions. This part of the brain is also the area where our primitive impulses arise, sexual and aggressive behavior. The impulses pass through the caudate nucleus, which filters them and only sends the most important onto the thalamus, which allows the individual to think more about these thoughts. Because the caudate nucleus allows unwelcome and unnecessary thoughts in, they become obsessions. Serotonin is a neurotransmitter that tempers or inhibits aggressive neurotransmitters in this part of the brain. Roger kept having intrusive thoughts about walking down the street and jumping some female person and trying to have sex with her. The thoughts bothered him so much that he would shake his head violently to get the thoughts out of his head when they occurred. Otherwise, normal Roger would walk down the street shaking his head. Roger's doctor found out when he caught Roger shaking his head while his female nurse took his blood pressure. He put Roger on Prozac, and the increased serotonin in his system cured his obsessions and stopped the necessary head shaking. Body dysmorphic disorder. People with body dysmorphic disorder are preoccupied with what they consider a defect in their appearance. The defect is either imaginary or so slight that the preoccupation is clearly excessive. The preoccupation causes significant distress or impairment in normal functioning, and it is not better accounted for by another disorder, for example, anorexia nervosa. Preoccupations involve wrinkles, complexion, facial proportions, the size or shape of the lips, the nose, eyebrows, cheeks, or ears, or thinning hair, areas of the head and face. The disorder can involve any area of the body showing an excessive concern over the size or shape of hands, feet, buttocks, breasts, genitals, body size, or overall build. A specifier with muscle dysmorphia has been added in the DSM-5 to capture a particular subset of sufferers who believe that their body build is too small or insufficiently muscular. People with body dysmorphic disorder can spend several hours each day checking the imagined defect or finding ways to cover up or hide it, and may alternate between almost constantly looking into mirrors and avoiding them altogether due to the distress associated with viewing themselves. Concern may lead them to isolate themselves from others. Depression, OCD, and social phobia may co-occur, and suicidal ideation may be present. Often individuals seek surgery or medical intervention and may even resort to self-surgery, although these interventions do not reduce the concern. Prevalence of body dysmorphic disorder estimated at 2 to 4% of the adult population. Prevalence may be higher in mental health settings and up to 15% of patients in dermatological settings. It appears to be equally likely in males and females, begins by adolescence, and tends to have a chronic course. Muscle dysmorphia occurs almost exclusively in males. Females are not likely to have comorbid eating disorders. And these are two individuals who had surgery. One wanted to be Ken, look like Ken, and the other, this lady, wanted to look like Barbie. Justin Judica and Valeria Lukanova. This is what they looked like before, and this is what they looked like after they had all that surgery. He's from the United States. She's from the Ukraine. This is what she looked like before. This is what she looks like now. Okay, this is Justin. Yeah, Justin has had 5 nose jobs. He's had chest implants, so he doesn't have to lift weights. He's had 198 procedures total, for a total of $250,000. Cheek and chin implants, bicep and tricep implants, butt implant. There's a higher prevalence of body dysmorphic disorder in those who have first-degree relatives with OCD. Childhood neglect and abuse are also risk factors for the condition. The current social and cultural emphasis on physical appearance likely plays a role in its development. A behavior model of body dysmorphic disorder suggests children might receive greater attention and reinforcement for their appearance than their behavior. Currently, both selective serotonin reuptake inhibitors and CBT, cognitive behavioral therapy, are considered first-line treatments for body dysmorphic disorder. Cognitive behavioral therapy has been shown to be more useful than selective serotonin reuptake inhibitors in the effective treatment of body dysmorphic disorder. That should be a D. Cognitive behavioral techniques employ education, relaxation, and systematic desensitization involving graduated exposure to the parts of the body that evoke distress. Cognitive behavioral therapy may be as effective on body dysmorphic disorder as it is on OCD. Collecting items that are later unable to be discarded, we're talking about hoarding disorder. Collecting items that are later unable to be discarded, persistent difficulty in parting with personal possessions regardless of active value, causes clinically significant distress or impairment and compromises living areas, as you can see. She's a hoarder. In addition to insight specifiers, diagnosis can be specified with excessive acquisition when items continue to be collected beyond available space to store them. I've seen garages that were full, completely full. I had a friend who, his wife wouldn't let him hoard in the house, so he bought a garage. He bought a garage and filled it right up. Oh man! And you would go over there and say, I've got one of those, and he'd go into his garage, and he would never be able to find anything. He could never find it. Said, "Well, I know I have one in here someplace. I'll keep looking, and I'll give it to you later." And of course, he never gave it to you, whatever it was that he was looking for. Very generous guy if he could find anything. Hoarding listed among symptoms of OCD and obsessive compulsive personality disorder in the DSM-4, but received independent status as a standing diagnosis in the DSM-5. Prevalence in the population was recently estimated at 5.8%. I have a brother with this. He's a biblio hoarder. He's a book hoarder. His house is, you can't walk in his house. There's books everywhere. Everywhere. That's all he spends his money on is books. All the beds. It was our family home. He lives in the home place, and people used to visit, and they'd have someplace to sleep. But now he doesn't even sleep in his own bed. His bedroom is full of books. My old bedroom is full of books. You can still get to the bed, but there's just books everywhere. They're stacked everywhere. It's amazing. Hoarding disorders is 3 times more prevalent in older adults than younger adults and shows increased severity with each decade of life. Let's see, he was born in 51, so he is 74. I guess he's older, but he's been a book hoarder ever since my mother died. Of course, he was even hoarding books before she died, but now that the house is his, he's filled it up with books. I don't know what's going to happen when he dies. It tends to run in families. 50% of hoarders have a relative who also hoards. And I've got nieces. I have nieces on my sister's kids are hoarders. My sister's probably a hoarder too. I'm not sure. I've never been to her house. There's a little information on pharmacotherapy for hoarding. Multi-component cognitive behavioral intervention utilizing a version of ERP, gradually exposing hoarders to discarding and non-acquiring situations. There are shows on television about this. Together with training in organizing and decision-making skills and cognitive therapy for dysfunctional beliefs, was effective in controlled trial of 23 hoarders. And my wife would probably say I'm a book hoarder too. I don't like to throw away books. Trichotillomania. People with trichotillomania pull out their hair and show noticeable hair loss as a result. Episodes of hair pulling, which can be centered on any area of the body, but most often involves the scalp, eyebrows, or eyelashes, occur in bouts that may be brief or may extend for hours. Likelihood of hair pulling often is higher under stress, but also occurs when the person is relaxed or distracted, such as watching television. Increasing tension or urge to resist precedes the act, which itself is associated with pleasure, gratification, or relief. To qualify, significant distress or impairment is present and not associated with a medical condition such as skin inflammation or another mental disorder. And that's what it looks like. Trichotillomania. Hair loss is widely variable across cases, ranging from thinning to areas of baldness. Individuals often deny their hair pulling and attempt to hide the effects. They may avoid social situations due to the embarrassment. Trichotillomania is associated with mood disorders, anxiety disorders, and various obsessive compulsive spectrum conditions, as well as personality disorders and intellectual disability. 12-month prevalence estimates in the United States are 1% to 2%, with females showing a ratio of 10 to 1 over males. The course of disorders is variable, and the condition may come and go, remit, or persist into adulthood. There you go. Trichotillomania. The causes of trichotillomania are not well understood. It appears to aggregate in families. Some preliminary data indicate multiple gene involvement. Its similarity to obsessive compulsive disorder may suggest similar causal factors. It's supposed to be causal factors, not casual factors. But it differs from the condition in several ways as well, especially in the absence of obsessions. There you go. Is that a wig? Yeah, that's a wig, isn't it? The most effective treatment for trichotillomania is habit reversal therapy, a behavioral intervention that combines self-monitoring of hair pulling, training and awareness of high-risk situations that trigger hair pulling, stimulus control techniques to interfere with or prevent hair pulling, and alternate response interventions to require engagement in a substitute or incompatible activity when the temptation or urge to pull is present. The competing or incompatible response may include clenching a fist for 1 minute. Excoriation disorder, people with excoriation, skin picking disorder, recurrently pick at their skin, causing bleeding, scarring, and infections. This is very common with people who are meth heads. The condition tends to first appear in adolescence, often in association with acne, and most commonly involves the head and the face. Significant amounts of time, sometimes several hours per day, are spent in the activity. The condition is commonly associated with comorbid anxiety and depression. Its incidence may be as high as 5% in clinical samples. Among the general population, the lifetime prevalence in adults is 1.4%, with females showing a 3-to-1 ratio in prevalence over males. Excoriation disorder tends to run in families and is more common in those with OCD. And that's what it looks like. Dr. Phil, have me, Angela Hartlin on your show about dermatillomania, aka excoriation disorder, skin picking. Selective serotonin reuptake inhibitor medications may provide a degree of relief, although some case studies have not found medication to be very useful. Interventions based on competing response training, or HRT, have been employed in behavioral therapies with some success as well. Substance medication-induced obsessive compulsive and related disorders, repetitive body-focused behaviors that result from intoxication, withdrawal, or exposure to a medication, obsessive compulsive and related disorders due to another medical condition, other specified obsessive compulsive and related disorders, conditions which do not meet the criteria for the obsessive compulsive related disorders, unspecified obsessive compulsive and related disorders. 29% of combat veterans from Vietnam suffer from post-traumatic stress disorder. 22% more suffer from stress and related problems. My brother with the book hoarding fetish. That's not really a fetish. He just hoards books. He has PTSD. He was a combat veteran from Vietnam. He was there 70 and 71. Vietnam was the first time we ever diagnosed PTSD. And it wasn't until the 80s that we finally recognized that all these guys coming back who were suffering, 29% of them, had a disorder, and that's when we labeled it post-traumatic stress disorder. 10% of the veterans from the war still suffer from PTSD more than 45 years later. Actually, it's more than that. It's more like 55. Let's see. The war ended in 75, so that's 50 years. Yeah, more than 50 years. 25% of returning combat veterans had been arrested for some crime within 2 years of their return. Their divorce rate was twice that of the general population. Their suicide rate was 25% higher than the general population. One of the things my brother used to do, he used to go into bars. He wasn't much of a drinker, but he would go into bars and he'd pick a fight with somebody and he would start fighting and he'd fight everybody in the bar. Little bitty guys. He's, I'm not the biggest person in the world. He's actually smaller than I am, and he would go in there and he'd just clean the place out. Because when he fought like he did when he was at war. He had no rules, and he always won. PTSD, as the name implies, occurs sometime after the traumatic event. Acute stress disorder is a reaction to the stress soon after its occurrence. The two disorders have the same symptoms, only the time of onset separates them. The symptoms include re-experiencing the traumatic event, usually in night terrors, but sometimes triggered by some similar event as a flashback, like a helicopter. Avoidance, people will avoid activities that remind them of the trauma. Reduced responsiveness, they need detached from other people. They feel detached from other people. Increased arousal, anxiety, and guilt, they may feel overly alert and startled easily. They may feel guilty that they survived, while others, more worthy, did not. Often after a natural disaster, people will suffer from acute stress or PTSD. The terrorist attack on the World Trade Center has created many people who have the symptoms of the stress disorders. Rape is another form of trauma that can lead to acute stress and PTSD. 1 in 7 women is raped sometime in their life. 29% are under the age of 11. 32% are between the ages of 11 and 17. 29% are between 18 and 29. 80% of the rapes are by acquaintances or relatives. Rape is long-lasting as well as immediate effects on the mental status of the victim. One study showed that 94% of victims qualified for a clinical diagnosis of acute stress disorder 12 days after the assault. Studies done in 1992 through 1996 showed that women who had been raped had poorer physical well-being after the rape and visited their physicians twice as frequently than they did previously. Not everyone who suffers a trauma develops a stress disorder. Researchers have discovered that traumatic events trigger physical changes in the brain and the body that may cause the stress disorder. The neurotransmitter norepinephrine and the hormone cortisol are present in the human body in large amounts after a traumatic episode. Some researchers feel that sensitive personalities may react to the stress biochemicals more negatively than do less sensitive people. Researchers have found that people who develop stress the most readily are people who have psychological problems before the trauma. Researchers have discovered that individuals growing up in poverty are more likely to develop stress when faced with trauma. Other childhood experiences that bode PTSD, experiencing assault or abuse at a young age, children who are younger than 10 when their parents divorce. Individuals with weak social support are more likely to develop PTSD. The more severe the trauma, the more likely the individual will develop PTSD. And I can tell you that I do have PTSD, and it has to do with some of the things that I experienced when I was in the military. One of the things that I experienced was airplane crashes. We were the ones that were the morgue, and we didn't recover the bodies from the wreckage, but the cadaver was brought into us, and we had to draw blood and urine from the carcass if we could. Not the easiest thing in the world. Anyway, and one of the things that triggered that was the fact that the odor that I detected coming off of the burned body was very similar to my interpretation of what mutton smells like when it cooks. And so that was kind of a shock when I came to Dene College because every time they cooked mutton, I got a flashback. It was really kind of bizarre. But there were other individuals there that were also suffering from PTSD, and we dealt with it. We dealt with it the best we could, anyway. There are various forms of therapy: Xanax to reduce anxiety, Desiril to allow them to sleep throughout the night, flooding to make them deal with intrusive thoughts, therapy to make them come to grips with their trauma. And of course, since I've worked in medicine for such a long time, I thought I wasn't having any problems, but of course, that smell came back, as weird as that is. And that's it. Okay. So next week we'll talk about something else, something far more pleasant. I don't know what is